So can you hear us now?
Проверки связи. Профессор, вы можете ровно 10 минут что-нибудь сказать? Мы сейчас проверим, мы отключим свои микрофоны.
Okay. Is it better now? Can you test the system?
Вроде нормально. Сейчас тогда все, начали уже.
Jetzt geht's. Okay. Das sehen ist okay. Ja, dann wechseln wir das einfach. Okay, we're ready.
Құрметті әріптестер, ханымдар мен мырзалар, Galamdyq-sheshim Covid-19 ақпараттық арнасындағы бүгінгі шараға қатысқаныңыз үшін көп рахмет. Уважаемые коллеги, дамы и господа, благодарим вас за то, что присоединились к нам на сегодняшнем мероприятии в нашем информационном канале «Глобальное решение COVID-19». Я ваша ведущая Балжан Айдашева, преподаватель кафедры фундаментальной медицины Высшей школы медицины KazNU имени Аль-Фараби. Сіздің жүргізушіңіз Аль-Фараби атындағы Қазақ ұлттық университетінің медицина және денсаулық сақтау факультетінің фундаментальды медицина кафедрасының оқытушысы Балжан Айдашева. Сегодня наша тема – введение пациентов с COVID-19 при коморбидных состояниях. Фокус на ХОБЛ. Передаю слово нашему уважаемому профессору Нурлану Даулетбаеву, постоянному модератору наших конференций. Келесі сөзді біздің конференцияларымыздың тұрақты модераторы, құрметті профессор Нурлан Даулетбаевқа беремін. Now I'll give a word to our constant moderator, Honorable Professor Nurlan Dauletbaev.
Thank you, Baljan. Can you hear me well?
Yes, thank you.
Okay, and I'll try to put the presentation on the screen. Can you see it now?
Yes, we can see it clearly.
Okay, perfect. Today we are fortunate to have Professor Vogelmeier, who is director of the Department of Internal, Pulmonary and Critical Care Medicine at the University Hospital of Gießen and Marburg site in Marburg, Germany. He is the world leading specialist expert in COPD, which stands for chronic obstructive pulmonary disease. For several years now, he serves as a chair of the scientific committee of the International Committee Global Strategy for the Diagnosis, Management and Prevention of COPD, abbreviated as GOLD, COPD GOLD. Apart from this, he served until last year as the chair of the German Society for Internal Medicine. And now he assumed the post of as a special commissioner for digital medicine of the executive board of this society. And for many, many years, he is a scientific coordinator of the disease area COPD of the German Center for Lung Research. Dear Professor Vogelmeier, thank you so much for being with us. Today, we'll try to cover several topics. First of all, we'll discuss what is a comorbidity and how that affects the risk for both severe COPD and for mortality associated with, severe COVID-19 and for mortality associated with severe COVID-19. Because the topic of our interest is COPD, we will discuss frequent comorbidities and overlap of these comorbidities in COPD, as well as the elevated risk for severe COVID-19 in these patients. We will discuss different scenarios of management of COPD patients during COVID-19 pandemic, which will include handling of stable cases, stable duration of COPD, as well as exacerbated course of COPD, and of course, the management of COVID-19 in COPD patients. If we will have time, we'll address briefly antibiotics in severe COVID-19. I doubt very much that we'll have time for live questions and answers, but our audience can send the questions to us and we'll ask Professor to address those questions and we'll give our responses in a follow-up session. As usual, I'm bringing up some abbreviation on the screen so people can take snapshots. And these will range from COPD, which stands for chronic obstructive pulmonary disease, all the way to specific terminologies such as pulmonary function tests, relative risk, acute exacerbation of COPD, and so on. So why comorbidities are important in the context of severe COVID-19 and the associated mortality? This is a paper published on May 22nd, which presents the data from the registry of more than 200 hospitals in the UK. And this paper presents the spreadsheet, presents the so-called bidirectional graph. Bidirectional meaning that the bar graph can go both left and right. And I will guide the audience through the graph. It's a bit more complex. On the y-axis, we see the range of patients' ages ranging all the way from newborns to nonagenarians, people who are older than 90 years old. Whereas on the x-axis, we have cases, a number of cases. And this is divided between patients of male sex and female sex, and hence the name of bidirectional chart. What's important on this chart is also the color definitions. The blue stands for people who died because of severe COVID-19. Orange stands for people who are still, at the moment of publishing, of submission of this paper, we're still at the hospital. And pink or red are people who got discharged after the hospital, after hospitalization. And as you see, this graph demonstrates a very interesting age distribution of severe COVID-19 patients of young age below the year 4. They tend to have severe COVID-19. Following this, all the way up until the adulthood, the early adulthood, children don't tend to have severe COVID-19, and then we'll have an increasing curve all the way up until the octogenarians, people who have the age above 80. And we see a clear dominance of male sex, and as I mentioned before, older age is also associated with severe COVID-19. The several graphs I will just present briefly they emphasize the overwhelming presence of patients with chronic obstructive pulmonary disease among those who have severe COVID-19. So this is the slide from the same paper, and we also have an interesting graph which will Professor Fogelmeier will present this at some point later in a different form. What this graph presents is that patients with COPD also tend to have other comorbidities. So this circle stands for COPD, whereas this orange circle stands for chronic cardiac disease. And as we see, there is a severe overlap between the two morbidities. And the same is true for the diabetes. So people who have COPD many of them also tend to have diabetes. COPD is also associated with increased mortality due to COVID-19, and this is seen in the same British paper. So highlighted here as an increased relative risk for mortality. This is the paper from the United States presenting the data from above 2,000 patients from US hospitals, about 60 US hospitals. And the final data that I wanted to present is the data from Italy, from the province of Lombardy. And as we see in all these papers, COPD shows association with both severe COVID-19 and mortality. So with this, I would like to give
Okay, Welcome and hello also from my side. It's a great pleasure for me to be able to speak to you today. I was with Dr. Galamdyq-sheshim in Almaty last year, and I enjoyed that very much. And I do hope that we can sort of meet in person again in the future. So first of all, I mean, Dr. Galamdyk-sheshim already showed you how important comorbidities are in the context of COVID-19. And what is very important to understand is that COPD by itself is already a disease that is very much attached to other diseases. So here you see data from the Maastricht group, where they carefully evaluated a cohort of COPD patients. On top, you see the number of comorbidities per patient, and at the bottom, you see the comorbidities they observed. And when you take a closer look at the disease names that you find there, many of them, and the majority of them, have to do with metabolic syndrome and cardiovascular diseases or risk factors. And that's something that stands out in the COVID world right now, that these seems to be very prominent risk factors for a bad course of the disease. Next. So when we add the data up that are around and that are available in this regard, so there is no doubt that comorbidities in COPD are frequent. And there is a mix, or let's say there's an overlap of comorbidities in COPD patients and in COVID. And this makes the disease, the COVID-19 infection, specifically bad or difficult to deal with for COPD patients. So, one of the important issues is now, how can we deal with that in COPD individuals properly? Next. So that's the scenario that we'd like to talk about, and there are three scenarios here. Let's first talk about stable COPD. And one issue that has been discussed extensively is, what about the use of the COPD drugs that we usually have in place during the COVID-19 epidemic? And when here you see a description in a picture how the disease develops. It starts with cough and fever, then you have infiltrates, and if the course is bad, you may end up in an ARDS. And in each of these levels, inhaled corticosteroids may play a role, and a deleterious role. But so far, there are no data suggesting that this is true, that ICS or even oral corticosteroids are a problem in these patients. And to support that, I would like to share with you a study from China. And they evaluated patients that had been admitted to a hospital in Wuhan. They analyzed all kinds of data that they had from these patients, including outcomes and ARDS and death. And this is what they saw. In a subgroup of individuals, they had treated them with methylprednisolone. And what you can nicely see here is that the survival curves diverge in favor of using the steroid. So this was not a randomized trial, but at least it suggests that it's not risky to give steroids to patients with COVID-19. You may have heard that there is now a big mortality study now that has been finalized, and in the New England Journal, there's now a preliminary study report available suggesting that dexamethasone may be even a life-saving drug for patients with a severe course of the disease. So with this as a background, the Gold Committee published a guidance regarding COVID-19, saying that we are not aware of any scientific evidence that any kinds of steroids should be avoided. And the next recommendations is that patients should stay on their treatment, on their regular treatment, and not de-escalate by themselves without having the advice of their doctors. Next. Now, some other recommendations with regard to the treatment of COPD patients in stable disease. A problem that can come up is use of nebulizers. You may know that nebulizers generate an aerosol, and this can be risky for not so much for the patients themselves, but for the people who take care of them, for the relatives, for the people they live with them. And therefore, this should be only done if there is no alternative available. You can continue using them, but you should consider switching to other forms of inhaled therapy that are not that risky regarding aerosol generation. Oxygen should be continued if indicated. If the flow needs to be changed, then you should discuss that with the physician. And non-invasive ventilation therapy, that was a big issue when the whole epidemic started in Europe. There were data from Italy suggesting that this can be deleterious, not for the patients, but for the nurses and doctors. You may have heard that more than 100 nurses and doctors died in Italy from COVID-19, so that's a devastating message. But we learned now in the meantime that you cannot really, that the statement that this all comes from NIV is not correct. It had to do with a lot of other circumstances. I would say the problem was that they lost control during the height of the epidemic, and they didn't have personal protection measures in place and things like that. So the message is whatever is needed for the patient should be done. Next. Now let's go on to the scenario 2. Now a patient has COVID-19. So regarding the respiratory support, there is a stepwise approach. Coming back to my statement that I just made, that every patient should get what she or he needs. So the hospitalization is typically indicated when the breathing frequency is high and when the oxygen saturation is low. What we usually do when the patients are on the ward, on the regular ward, we give them oxygen, maybe even high flow oxygen. Prone positioning may help. What is interesting to know is that this form of lung involvement that we see in COVID-19 is different from many other forms. It's different in that way, for example, that the compliance of the lung is in most cases normal. So it's not, and that of course has consequences. So changing of the position can help a lot. We put patients to an ICU when they are hypoxemic, even under high flow oxygen condition, when they have a circulatory problem, or when they get something what we call the cytokine storm, when the lab tests, this is just one of them, LDH, but there are others. The best marker is ferritin. IL-6 is also a good marker that tell you that something goes out of range. As I said, NIV can be tried, but you should always be aware that you may have to escalate to IV. When patients are very bad, then you should go to invasive ventilation right away. Next. Now, a very important general rule is prophylactic antibiotics are not recommended. I will show you in a minute what I mean by that, but that's a very important statement. You should do cultures. You should try to find out if there is a problem with a co-infection. Some hospitals do a lot of bronchoalveolar lavages, others don't do it at all. There is no doubt that this is a risk for people that are involved in the procedure, and it may deteriorate gas exchange for the patient, so the indication should be clear. Then targeted antibiotic treatment. So if you use antibiotics, you should find out or try to find out what the risk situation of the patient is and then adapt your antibiotic therapy to that. Volume substitution should be done sparingly, and this has to do with the fact that I will show you some data in this regard later on again, that COVID-19 is not a lung disease. It's a disease of the whole body. In particular, it's a disease of the vessels. Next. Now, coming to the issue of co-infections. There are several studies that looked into that. This, to my knowledge, is the best of them. These are patients from a hospital in Wuhan, and they evaluated all kinds of features of these patients and looked into death and survival. Next. And this is what they found. And you see here encircled in blue, the likelihood of a bacterial infection. Total, it was more than 40%. The survival patients around 35%. And the patients who died, it was more than 80%. So this suggests if comorbidity, if a co-infection with bacteria happens, then this is prognostically relevant. Second, not everybody has it. So it's important that you do evaluate the patient with regard to infections. What we do, for example, we monitor very closely CRP levels. We will monitor very closely procalcitonin. And in addition to that, repeated cultures are mandatory. Next. What is also important is that we have to give patients the advice that they should get the vaccines that they should get. So for COPD patients, there should be an influenza vaccine in place. In addition to that, they should be vaccinated against pneumococci. You know that there are two vaccines around, the 23-valent and the 13-valent. And whatever you have in place in your country, you should use. Normally, the best way of dealing with that is to have a sequential vaccination with both vaccines, but where this is not available, I would say for the start, one should do it. Next. Now, during respiratory support, what is also extremely important is that you have a personal protective equipment in place. We have all the patients in negative pressure rooms. Patients should wear a mask over the cannula and with high flow oxygen. Leakage avoidance is an important issue when it comes to NIV. Then, of course, you should have a double limb respiratory circuit with appropriate filters. Intubation is best done as a planned intervention. If you work in a place where there are a lot of cases, one good advice is that you have designated intubation teams. The advantage of that is that the people who do this are always the same. They are very well trained. They know exactly what they do. They are aware of the personal protection issues and things like that. And of course, video laryngoscope is very helpful when you try to keep a distance. Next. Now, weaning off ventilator, the way we do it as usual. So we try to de-escalate treatment. We start with control, reduce pressure support, goes to CPAP, and then do extubation. If necessary, we use NIV after the extubation. This can be an issue when you have a COPD patient who is borderline with gas exchange anyway. And tracheostomy is usually considered when patients are more than 7 days on IV. There are other centers that do it very early in the course. I think 7 days is a good compromise. Next. Now, I said beforehand that this is not a pure lung disease. So what you see here is the involvement of the disease. In blue, viral response phase, and then you see in orange the very important later course of the disease, the so-called host inflammatory response phase. And when you look at the bottom in this area that's encircled in orange, you'll nicely see that at the lower corner on the right side, you see this very high. You can find very high lab test data with regard to inflammatory markers, but you can also find elevated markers for cardiac stress proteins and enzymes as a consequence of the involvement of the heart. Next. Now, that this is a disease that has a lot to do with changes of the issues of the coagulation system is very nicely shown here. This is a study, a post-mortem study, where they evaluated intraalveolar septa from in this case, a patient had died from COVID-19, and marked with the arrow or the arrows, you see microthrombi in the interalveolar septa. Next. And you do not only find thrombi in the lung vessels, in addition to that, you also find new vessels. So on the left-hand side, you see a scanning electron micrograph of a normal lung. On the right-hand side, you see that of a patient who died from a COVID-19 infection. And what you can nicely see is they have more vessels than the others. And these vessels look very strange. These are not normal vessels. It comes close to vessels that you see in cancer patients. So there is angiogenesis ongoing in these individuals. And in these new vessels, you find a lot of thrombi. Next. Here you see on the other autopsy findings from patients with COVID-19. At the top, in A and B, you see how the lung looks like. You see these patchy changes. Some areas very much diseased, others normal. And then at the bottom, you see two different types of big pulmonary emboli. So what this means in general is when you have a patient that with COVID-19 on your intensive care unit and the patient gets worse with gas exchange suddenly without any good explanation, one of the differential diagnoses that you have to consider is pulmonary embolism. And therefore we have them all the patients on the ICU in full anticoagulation. And if something like that happens, they go straight to the radiology department to do a spiral CT. Next. The problems with the vessels you can not only find in the lung or in the heart, there's also something happening in the heart, but also in other organs. So here you see livedo rashes at the feet, at the right foot. And when you then do a biopsy here, you see very nicely that in the middle of the picture that there is a big arterial thrombus. So you find thrombi not only in veins, but also in arteries. So it seems to be an ubiquitous problem of all kinds of vessels. Next. Now, what do you do when a patient is discharged? Let me rephrase it. How are patients doing when they survive COVID-19? They are very weak. That's a typical finding. And they are not only weak regarding their respiratory muscles, so they can't breathe well, and many of them are still dyspneic, although the disease is already over for weeks, but also for the skeletal muscles. They can barely move. They have fatigue. Then, of course, there are these issues like anxiety and depression, demoralization symptoms. And what we do is then we send these patients to qualified rehab centers, and there are now several app-based rehab programs under evaluations that may help in countries and in areas of countries where you do not have adequate access to qualified rehab centers. Next. Now, the third issue is, what about a patient that he has COPD and during COVID-19, the COVID-19 epidemic gets worse with the respiratory situation? So the differential diagnosis between exacerbation of COPD and COVID-19, and this can be quite tricky. And one thing that we have to keep in mind, fever is not a typical symptom of a COPD exacerbation. So if a patient with COPD develops fever, you have to think about infection and not about exacerbation. Next. Another issue is when you are not sure, imaging can help a lot. So what we do in our place is that we do a lot of imaging in patients that come in the hospital, in the emergency care center with COPD and suspected COPD exacerbation. Anytime we have a suspicion that there may be COVID-19, they go to the CT scanner, and here you see 4 different cases. On the left upper side, you see a case, a very mild case, and then we go clockwise, and it gets worse around the clock. What is very interesting is there is a correlation between the intensity and the extent of the infiltrates in the CT and the course of the disease. Or in other words, the more infiltrates you see, the more you have to worry about the patient. Now, I think now we have come to an end with the presentation that we wanted to show you. I would like to give you some summary recommendations. And first of all, this is an evolving field. So this is work in progress. A lot of what you have seen may need to be changed in the months to come. But I would say it gives you some idea how we think about this context of COPD and COVID-19 for the time being. Second, COPD patients are at risk for developing COVID-19. And second, they are at risk of a severe course of the disease. What can you do about it? First of all, COPD patients should get their regular treatment. They should not de-escalate by themselves. They should get the appropriate vaccines. In case they get worse, you have to consider that it may not be an exacerbation of COPD, but a COVID-19 infection. Take the appropriate measures. Then when you take care of the patients in the hospital, it depends on the gas exchange system and other clinical features of the patients, where they go and what you do with them. Antibiotics should be restricted to patients where there is clear evidence for an infection. And regarding ventilatory support and things like that, every patient should get the appropriate measure that he or she needs. That's the most important rule when it comes to ventilatory support. With this, I would like to end my presentation and hand over to Dr. Daletbaev again.
If we have questions, okay, let me. So I will ask several questions so that you will have a chance then, so we can switch and then you have a chance of answering several questions at once. My first question is, there is a big debate in Kazakhstan, which is now experiencing this second wave of coronavirus. Mid-May, they lifted restrictions, as it turns out, too early. And now they have increased number of cases. And one of the problems is obviously hospital beds and intensive care units, especially. So what do you think of portable concentrators as an interim measure? At least some of them can get a peak value of up to 4 or 5 liters per minute, which is probably not a good substitute, but at least as a temporary measure. Second question was if there is an experience, with turning regular wards into negative pressure rooms by diverting the pressure. That's the second. And there is something called ante-room, where personnel can change. And so that's, do you have any experience with this? A big question is, and since you mentioned the anticoagulation, what do you think of anticoagulation, oral anticoagulation in outpatients? So at least these 3 questions we've been discussing on and off before the conference. And once you will answer this, I will gather further questions.
Okay, thank you.
You know, these are very good questions, and I would like to try to answer them. First of all, portable concentrators. I mean, the rule is you take what you have. I mean, we, for example, we have a working group here that transformed CPAP instruments for obstructive sleep apnea in ventilators. So, and a lot of people tried to sort of come up with innovative ideas, what you can, if there is a shortage of classical ventilators. So I would go that far to say, whatever you have locally that can used as a bridging scenario, use it. But in wards, like hospitalized patients, or we don't. I mean, we don't have to do that because we have oxygen everywhere, and we have all kinds of infrastructure that is helpful then. But if you don't have that, Kazakhstan is a large country, a thin population, and some areas may not have coverage. Okay, that's why. Okay, then I would say you take what you have. I mean, there is, and then you try, of course, if possible, to transfer the patient to a center where he or she can be taken care of. Then the issue of negative pressure. The negative pressure is not mandatory, so it's good to have it for obvious reasons. But if you don't have it, then the anteroom scenario is extremely helpful. And in the hospital in Germany, where they had seen a lot of patients, what they did is they sort of separated or they defined several areas of the hospital. So there was one COVID area of the hospital and there was a COVID-free area of the hospital. And there were sort of borders in between, and they had all kinds of double doors and things like that installed. And in the COVID-19 area, everybody was wearing protective gowns. Anterooms is great. So if you cannot do this one, what I just suggested, anterooms are also a good solution. Then anticoagulation is a big issue. And the answer is nobody knows. What most intensive care units do is when patients are on the intensive care unit, most intensive care units give them full anticoagulation for the reasons that I mentioned. But the problem with COVID-19 is also that not only you see thrombosis, but you can also see bleeding. And we saw some patients that had very severe bleedings actually, or quite severe bleedings, suggesting that it's not just an issue of thrombosis. So there is something else, there can be something else wrong that goes totally in another direction. And therefore, the rule in this place is that we, in patients that are not in the ICU, that are only in the normal ward, they only get prophylactic low molecular heparin and nothing else. So that's the way we do it here.
To administer anticoagulation. Well, there are two things: anticoagulation, antithrombotic therapy. And in many instances, doctors administer this without having coagulogram, which I find as a dangerous scenario. As you just mentioned, the bleeding. And I sometimes ask the colleagues, do you know that this patient will not develop bleeding, especially patients who have high blood pressure? They already take ACC. And on top of this, if you add anticoagulation, you need to watch this person so that they don't get bleeding, gastrointestinal bleeding, etc. And you answer this question. So if it's a full anticoagulation, then only under observation in ICU wards, okay. So the other question that was discussed is that there had been a practice in Kazakhstan when a radiologist says a patient has not infiltrate. For some reason, they say on CT there is a pneumonia on both sides, and immediately antibiotics are administered. What do you hold of this?
Yeah, that's something a radiologist should not say. A radiologist should always say what he or she sees and should describe that. You know, when you look at that, even when you see findings like the one that we have on the screen now, I mean, this is not specific. So even when you see something like that, it could be something else than COVID-19. I think it's a fair statement that these are infiltrates, and it's a fair statement that they give you in the scenario that we're right now, that there is a suspicion of COVID-19, that you have to look for it. But you can never be sure. And of course, it could be something else. For example, one differential, you see similar pictures when patients have autoimmune lung disease. So this is not specific, and by no means is it clear that it has anything to do with bacteria. So I would not use this as an indication for starting antibiotic treatment.
Idea of administering aspirin ACC to patients with COPD plus COVID-19, I guess in the context of high blood pressure.
As you already said, this can be quite tricky. And if things go wrong, and then you add some heparin to that, or one of the oral anticoagulants, you may end up in some kind of bleeding problem. So when patients have that for cardiovascular reasons, and the cardiovascular reason is good, then we stick to that, but we're always aware of the risk for the patients.
About maybe making a registry of patients with COPD, and I will explain you in what context. When I was searching for the literature for our presentation, I was not clear how they define patients. For example, a patient is having COPD with diabetes and suppose a cardiovascular problem. Will he or she appear in that a nice summary as a person who has COPD? And we both know that COPD is under-recognized in the population. Do you think that, and the follow-up question would be, there is a big debate throughout the ATS and ERS about resuming the pulmonary function and normal diagnostic services, because COPD cannot be, diagnosis cannot be done without having proper spirometry findings. What do you suggest on this case? Is it okay to continue with active?
Yeah, of course, that's an important issue. How do you diagnosis without spirometry? I think you can't. I mean, there is no way that you can make the diagnosis without having a proper lung function test. And there are filters that you can use. At least in Germany, there are filters available that have been tested for viruses and that are safe in this regard. And there are now, of course, there is very cheap lung function equipment, handheld, where you do not have to bother about that at all, where every patient has sort of his own system and you only have a very small device that is connected via Bluetooth to your personal phone. So I think you can get around these issues even in areas where you have a lot of cases. But I'm absolutely with you that that is extremely difficult now to know or to be, I would say it's impossible to be sure that all the data that we've seen so far are correct, because there are probably a lot of cases that have not been diagnosed with COPD. And in addition to that, if a patient has several diseases at the same time, you never know what the real risk scenario is. What is very interesting is that in many instances, you find sort of the typical scenario that you see in a COPD patient, that there is not only one disease, but there is a guy who is obese, who has metabolic syndrome, who has some cardiovascular issue, and in addition to that, COPD.
More personalized advice on management of COPD. You just mentioned obesity. You just mentioned cardiovascular disease. Diabetes is a big issue. And obviously, osteoporosis is also, you just mentioned calcium. Could we expect some sort of a personalized management recommendation?
Well, first of all, there in the new goal document that published in November of this year, there will be an extra chapter regarding COPD and COVID-19. So we try to summarize and analyze all the available literature with regards to COPD and COVID-19. Second, of course, you're right, we need more recommendations and more specific recommendations regarding COPD plus comorbidities. The problem is that the available evidence is very poor. So that's an issue that gives us sort of, that limits our ability to come to very firm conclusions for the time being.
A favorite topic. So antitrypsin deficiency, somebody sends regards. He was Ardak, his name is Ardak. You were his supervisor, and alpha-1 antitrypsin deficiency. He's happy to hear you. What about anticoagulant therapy in those patients?
Thank you, Ardak. That's a good question. I mean, how our patients are doing with this, with a disorder like that in a situation like that we have now. Interestingly, so far, there are only very few cases reported of COVID-19 plus alpha-1 antitrypsin deficiency. I think it may have to do with the fact that patients got so worried that they did not leave their homes anymore. Second is there are now very exciting new data suggesting that alpha-1 antitrypsin may be able to interfere with the COVID-19 infection. That it may be, that's a very weak maybe for the time being, it's a hypothesis that it may be used as a drug for treating patients with COVID infection. There are now in vitro data suggesting that COVID-19 and alpha-1 antitrypsin, that there is an interaction, that sort of the infectious potential of COVID-19 is reduced when alpha-1 antitrypsin is around. So these are very preliminary data, but it's an exciting area.
Are on biologic drugs. Is there any specific issues because they may have the immune system is already affected by both asthma and biologic drug? Any specific issues on pharmacological therapy and non-pharmacological therapy?
There have been published recommendations by several huge bodies regarding asthma treatment, one of them by GINA, suggesting that, first of all, patients with more milder forms of asthma do not have an increased risk. At least it looks like that so far. Second, asthmatics should not change their treatment. The recommendations are the same as in COPD. They should stick to their ICS. And third, in severe asthma with treatment of biologics, the biologics should be continued. There is no evidence and no reason to assume that the biologic treatment may cause any kinds of problems and issues with regard to the COVID infection.
If you don't mind, we can go back to a couple slides of, I believe that they ask a question specifically to this. For example, oxygen delivery rate.
Yeah, and we one issue is let me explain that in a little bit more detail. I said before that one of the very specific features of this disease is that in many cases, at least in the beginning of the disease, when they start getting worse, that the lung compliance is normal. As a consequence of that, is what you find is that these patients are typically quite hypoxemic, but the PCO2 is normal or reduced. So this is a different scenario than the usual ARDS that you see, because in the usual ARDS, you not only see hypoxia, but in addition to that, you see a PCO2, elevated PCO2. So now so this tells us that the pathophysiology here is different from the classical ARDS. And therefore, other measures can be tried. And there are several groups that say, and there are experiences in particular from the US, that you should try to avoid intubation as long as possible. I am not so sure this is a good idea. I mean, the Americans, for example, what they do is they always use high flow oxygen. They try to use prone positioning even in patients that are not intubated. And I must say we tried that too. And in some patients, it really makes a difference. Patients get better. But our logic is, or the way we proceed is that we look at each patient individually, look at his or her personal specific situation, and adapt the measures to the situation of the patient. And the numbers that are given on here are just, I mean, this is just approximations. You always have to take a look at the patient, how he or she is doing. If there are patients that are severely hypoxemic with very little symptoms, so there you would not intubate. You would try to avoid intubation. And others that, although the gases and the numbers look still quite good, are extremely dyspneic. And then of course you would just, because patients are suffering so much, you would intubate them earlier. So that means these numbers just give you an idea where you are, but I would not see them like this is the rule you always have to follow.
Just to give them some number, 2 to 4 liters per minute, that it is something that you would consider as high flow oxygen?
No, that's not high flow. I mean, high flow goes up to 40 liters and more.
Okay.
So that's high flow. I mean, that what you're describing are the normal rates that you use by giving normal oxygen. But there are now instruments around that can go up to 60, even 90 liters per minute. But then you get to a situation where you, and the question is, what difference does it make? It's not logical to assume that's the oxygen. The point is that you give some positive pressure when you have such high oxygen rates, and this positive pressure may improve the situation of the patient. So it's not just the oxygen that plays a role here. In addition to that, it has to do with that it's more or less kind of a CPAP system with a low pressure.
Scenario when you are ready for the patient to be intubated, would you consider using CPAP on the ventilator so that the patient can quickly be transferred into invasive ventilation, switch to invasive ventilation?
Yeah, we have machines that are very versatile, that can do all different modes, and we typically keep them on the same ventilator. With a few exceptions, there are some patients that are very obese, and in these patients, other types of ventilators may be better. But typically we have them on the same ventilator, on CPAP and then on invasive ventilation.
Your own schedule, busy schedules, and any further questions, we would encourage people to send the questions. I'll just put the last slide, and here is the email address where people can send the questions, and I will ask our keynote speaker to answer these questions, and we'll have a follow-up session. So Baljan, we can wrap up the session.
Okay. Большое спасибо за эту очень интересную, информативную дискуссию. Thank you very much for this interesting and very informative discussion. Благодарим участников конференции, кто был на связи и смотрит нас на YouTube-канале Galamdyq-sheshim. Galamdyq-sheshim YouTube арнасында осы конференцияға назар салғаныңыз үшін алғысымызды білдіреміз. Вы можете высылать ваши вопросы и предлагать темы для следующих конференций по почте galamdyq-sheshim.kz@gmail.com galamdyq-sheshim.kz@gmail.com электронды пошта арқылы сұрақтарыңызды жіберсеңіз, немесе қызықтырған тақырыптарды ұсынсаңыз болады. Сау саламат болыңыздар. Thank you and goodbye.